I've been in Beverly Hills for about 25 years. I was in Encino for the first 10. And my dad was a pharmacist, and I kind of grew up in Woodland Hills, and I wanted somewhere in the sciences. And pharmacy just didn't seem great because it was being taken over by corporate at the time. And so I ended up being a dentist. I thought, close enough. And it's been a great profession, and I've really loved it. And I started out, I went to UOP dental school and graduated in '89. And then I basically was very interested in veneers, and I was interested in white fillings. And at the time, they really didn't know how to bond to dentin. It was like, we only knew how to bond to enamel. And I kind of, hello, nice to see you. Thank you for coming. We're just starting. Go ahead and get some pizza and there's water there. And so I was very interested in non-metal dentistry. And once I figured out they understood how to bond to dentin, it was around 1995, I decided I got to go learn that. So I learned it, and I started doing lots of inlays and onlays on the back teeth instead of mercury fillings and amalgam fillings. And then from that, I started doing porcelain veneers. And then with the bonding was so good, and I was so impressed that I thought maybe I can do over the biting table with this non-metal material. And so I started getting into full mouth rehabilitation, but I wasn't impressed with what I learned in dental school with centric relation and the way that we would find the bite from a centric relation point of view. And like Frankfurt plane, I couldn't understand why I was going to Frankfurt plane. Wasn't level with the occlusal plane. And then so I ended up getting into what's called physiologic dentistry, or more of a neuromuscular dentistry. And what that means is that we're basically incorporating the muscles into the diagnosis. And so that's kind of been my journey. And then with that dentistry, it helps people with headaches and neck pain and people that are having lots of tension. And so I started treating patients with TMJ. I got really good at it. And TMJ patients are great if you know how to help them. And they become you're like a real doctor, and they really appreciate the fact that you help them. And so I've gotten a lot of gratitude from that. And so that's about me. And that's how I got here. And so what happens is, today we're going to talk about full mouth rehabilitation, and we're going to talk about it doing it in a physiologic way. And so the way that I end up doing a lot of these cases is I get a new patient, and I want to find out what the patient is here for. So what I do is I take a full head CT scan, and I go in with a professional camera, the Canon, and I take a photographic series. And then I say to the patient, come in my office, we're going to bring up all the data and let's talk. And I find out what the patient's needs are and what they're really looking for. And a lot of them come in wanting something. So I want to know what that is. So I interview them. And I've kind of listened to patients, and some people, I kind of break them into three categories: a tooth doctor, a smile doctor, a mouth doctor. What are they looking for? I have some cavities, I want them filled, and they need a tooth doctor. I hate my smile, I want to fix it, whether it's ortho, veneers, whatever. They want a smile doctor. But my mouth's a mess, and I just need your help me on all facets of dentistry. That would be a mouth doctor. And what I found through my career is very hard to move people out of their slots. So when they tell me they want a tooth doctor, it's hard to say, okay, you want a tooth doctor? Let me be a mouth doctor for you. They're not interested. And it's very difficult to move them out of their little categories. And so I'm looking for people that say, I want a mouth doctor. That's what I enjoy doing. So I kind of advertise for it, and I kind of like have my marketing towards it because I like doing full mouth rehabilitation. And I'm going to explain today how I do it on different levels, even the whole concept of how I do it. So the patient like this comes in, referred by her sister. And I mean, you look at this patient and she's totally collapsed over here on this side. Like when she bites, she can't even, I mean, the gums are hitting the teeth on the bottom there. And looks like a lot of her bite is anterior. She's getting a lot of contact here and she's missing her bicuspids. This is a full mouth rehab. And I thought I would just show you what an end result looks like on the same patient because she came in yesterday and I went ahead and took a picture of her. Looks a little too white with the light, but it's not that white. And she just had some fun, Sam, our marketing lady, for Instagram. But so get to the next slide here. Are we going to get there? Let me get back and hit slideshow. So before you can do a full mouth rehabilitation, I break that into two phases, phase 1 and phase 2. So phase 2 is let's do the full mouth rehabilitation. You can't do it unless you have the green light. And the green light's like in Hollywood. You can't make your movie unless you have the green light. So all the pieces have to be green before you can start. And I made a little slide here of like what the green light entails. So I'm going to read through them, but smile design, and Bruce Crispin here is a legend, but we know how difficult smile design is. You got to take courses to get your cosmetic skills up, and so you understand how to make a smile makeover. But what is the smile like? What is the patient's expectations with the smile? And we need to understand that before you can do this full mouth rehab. Obviously the periodontal condition, are the gums healthy? Do they need surgery? Do they need root planing? But you can't do the full mouth rehab without making sure that the foundation is strong and healthy. Is there decay? Is there decay in the mouth? How bad is the decay? Is it active decay? Is it, can it wait until we do the full mouth rehab? Because we like to be very efficient. We don't want to put the patient through unnecessary treatment. So basically, we look and see that if the decay needs to be cleaned up prior to doing the full mouth rehab, then we would do that. We look at all the teeth, whether they need root canals. We test all the teeth for vitality. We make sure that they're all healthy. And we look at a CT scan. I'm going to go through that to show you how that works. But if they have missing teeth, bridges, implants, what are we doing? Are we going to put implants in prior to doing the full mouth rehab? All these things can delay the actual work of doing full mouth rehabilitation. And all of it has to turn green. Every one of those pieces of pie need to be green before I can do it. The bite is what we're going to talk about, and we're going to delve into the bite, because doing a full mouth rehab with a proper bite is what separates the dentistry. And I think when the bite's in a really physiologic place, the patient's face looks prettier. It's more relaxed and it's more in alignment. So it's not just the mouth and the bite, it affects everything. And so is the bite healthy? Is the bite not healthy? So if someone came in and said, I want to do all my teeth, well, why would I change their bite if the bite was good? So I want to look and see if the bite's good or not. And so many dentists do not change the bite. They leave people in their habitual bite. And I think sometimes that's a myth. They're not doing the patient justice by doing that it should be changed. And you shouldn't be scared to change the bite. And This is what we call phase one. We're still in the green light period. And what this is a patient with a very deep bite. And they have, Bruce, what would you call this? Is this called reverse curvus spee, or is this called just exaggerated curvus spee? Which one is it?
I don't know.
So
It's almost like hyperruption of the anterior.
So what I do is, when I find the bite, and I'm going to show you how I find the bite, but what I do is I actually put a fake bite on top of their teeth prior to doing the work, and I test it out. It is very important that you do this, because if you don't do it and something goes wrong, these type of procedures come with a big legal medical thing, because you're working on 28 teeth and you have to be very careful with everything. And so testing out the bite is almost a must, because if you just go and prep teeth for a full mouth and change the bite without testing it, you'll be in trouble. So by the dental board. I had a patient who I did a full mouth, but I did do a thing like that, and then she wasn't happy for some reason, and she went to a prosthodontist in the Inland Empire, and he was blown away by how beautiful the work was. And I said, can you send me an email with that? And so he did, and then 3 or 4 years later, I got a complaint from the board, and luckily I had that letter, and it just went away. So anyways, one of the things they were interested in was, did you just rush into full mouth procedure, or did you test the bite first? And I proved that I did have the patient in some sort of trial bite or orthotic. If you look really closely, you can see this white material above her crowns. Do you see her crowns? You can see my material. When she bites, she has a deep bite. You can't see the lower teeth. When she bites on this trial bite, the lower jaw was back here. Now it's a little down and forward, and it's showing a little better up in here. And I have a much more normal vertical dimension on this patient by just raising up the back molars, making it level with the horizon. And I'm going to show you how we do that. But we always have a trial bite on the patient prior to, if we're changing the bite, before doing full mouth rehabilitation. So what we're looking at, I'm looking at a CT scan, and I'm scouring, and I want to know what this patient's jaw is like. And so I'm going to look at both TMJs, and I want to see if they're compressed or not. This one's very flat on the surface. It's probably eroding. Also, when you see the coronoid process this high, the anterior temporalis muscle attaches to the coronoid process. And so when it's really tight, you're going to get what's called elongation of the bone, and that's a sign that this person has strong, tight muscles. And so I'm looking at all this prior to doing my full mouth. I'm scouring and looking for signs. Is this patient going to be difficult, or is this going to be an easy patient? So when you look at the patient's neck, we look for a nice, on C1, we like to see a lot of decompression, at least 8.5 millimeters between the head and C1, and 8.5 millimeters between C1 and C2, and about 20 millimeters from CO all the way to C2. And when you look at the bite plane here, typically the bite plane and C1, bite plane and C1 are going to have a relationship. So when you change the bite, you're going to change some of the relationship of how the head is sitting on top of the cervical spine. This is very compressed. You can see how this patient has very little room between the head and C1 and C2. It's very, very compressed. And so we're looking at the neck to see if it's a good neck or a bad neck. This is called bicuspid drop-off, and this is the same patient, but I'm just showing you that it's things that we'll look at with the photographic series. And we're kind of going back and forth between photos and CT scan, but this is what I do. I take the CT and I take photos and I throw them up on the screen. So this patient, this right joint, on the superior capsule is very flat, is very close to the glenoid fossa wall. It's like it doesn't have room for a disc. It's very compressed. Looking on the lateral side, you can see how it's almost bone on bone. Now, do you want to restore a patient like that in full mouth without changing the bite and leaving them in a habitual bite with a joint like that? You want to raise the bite up. And that's what's the beautiful thing about the lower jaw is that the condyle and the lower jaw, the teeth of the lower jaw are on the same bone. So if you raise up those teeth, you're going to create some space in the joint. And so these are called gonial notches. Gonial notches, and they're from clenching. And you look at the CT scan and you see these notches on the, if you look at our skull, they don't have any gonial notches here. It's nice and flat. So I'm looking, that's a sign of a clencher. The high coronoid process is a sign of a heavy muscle of the temporalis anterior. This is interesting, but this is looking up on someone on a CAT scan, and this is the lateral pterygoid plate of the sphenoid bone. And when you see it longer, or you see this bone growing here, like it's not even with the other, with the medial and lateral plate here, the pterygoid muscle attaching to it, it's a sign that the lateral pterygoid muscle really tight, pulling on that bone. So I'm just picking up signs from the CT scan. And this is how we think. I mean, I'm looking at this patient and I see how deep the bite is between the anterior, lower anterior and the upper anterior, and how it's trapped behind that maxilla bone. But I also look at the airway and I measure the airway and I see how much, what is the airway space and what's the millimeter volume there. If I'm going to take this lower jaw and I'm going to move it down and forward to here, all this tongue and everything's going to follow and it's going to enhance the airway. So when I have a CT scan, I don't know how many of you or any of you do sleep apnea treatment or do anything for sleep, but we have sleep studies in our office. Now, we're not allowed to treat for sleep, but we're allowed to screen for sleep. And so with the sleep pulmonologist, they can give an RX, then we can do it, then we can bill. If you want to try and bill their insurance, it's a big game and it's hard. Or we just have them and we just charge the patient $500 for a sleep study, and it gets read on these watch pads. And we try and do that before we do the full mouth rehab. We kind of want to know as much information as we can get. So this is a way I can also enhance the airway. So I've been doing what's called physiologic dentistry, meaning I'm bringing muscles into the diagnosis. I'm sort of anti-CR. I know we have a pros here, but I don't believe in CR. And I'm 35 years as a dentist, and it's never been my thing. And it's like, what is CR? Like anterior, superior. It's a joint position. But there's muscles that attach to this lower jaw. And with the technology today, we can now measure muscle activity on the lower jaw. And so I got into what's called EMG data, electromyography. And I thought I would measure some of the lower jaw and just see what the muscles are like. Because we're working in this field in the mouth, and we've got 4 main muscles coming from the skull down to this lower jaw, and I want to know what's going on with them. And so I'm going to actually take my bite from a relaxed muscle position, and I don't even care about CR. I don't care about anterior guidance. I'm going to do group function. Anterior guidance is cuspid guidance is I'm at cuspid guidance. It's for parafunctional habits, from what I was taught, that they build in the bite to roll on the cuspid because to just prevent the teeth from breaking or the forces. But when you have a nice passive bite, you don't have to worry about it. And it's very rare that the dentistry breaks or I have a problem with it, but I don't really do any cuspid guidance. And I'm just going for a relaxed, decompressed jaw joint. I'm letting the muscles guide it where it wants to go. And so the way that I find the bite, and that's what I was going to show you, is we look at someone's teeth, and when you look at like this patient's teeth, there's a lot of wear on the anterior teeth. And what's surprising is that when you take those wear facets in the front and you kind of put the two front teeth together over those wear facets, that's kind of, you're listening to the muscles, because this is where the muscles have been wearing those teeth for this patient's 20, 30 years of living or whatever long. So like the horse whisperer or whoever, I'm looking at the teeth and I'm like getting clues where these patients' muscles have been wearing down. So when I gently put this right here over the wear facets, it's like a jigsaw puzzle fitting into it. And with this handheld articulator, I just kind of raise it up to a good physiologic distance, meaning like a golden vertical type distance. And you can see how this negative curvus B is also coming out here. And I'm just going to take I take clear, see-through translucent putty, and I make what's called an anterior alignment guide. And that's what I did. I just kind of pumped in this little piece of putty in here, and it sets, but this fits right in here like this. And what I do is I'm going to put that piece in the patient's mouth, and I'm going to actually try and relax their muscles using a TENS machine. And a TENS machine is been around for about 100 years. And I think that there's a lot of studies on them that show that what they do is they can break up muscle activity from what we call high activity to low activity. And that's what I'm looking for, low activity on a patient. I want to know where that is. So I want to break up the muscle tension. Sort of like a piece of meat. You tenderize it. That's what this TENS is doing on these muscles. When you put a TENS on the patient, is we go right into the coronoid notch right here, and cranial nerve 5 passes right through there. So, and cranial nerve 7. So what happens is you get some facial twitching from the cranial nerve, from the facial nerve. But if you go a little harder and you put your pinky on the lower teeth and you turn up the TENS machine, the lower jaw will start to go up and down. And you there's a threshold where you go down, I turn it back down to where I can't feel it anymore. And then I go up to just where I can barely feel it. You don't want it slamming, you don't want the teeth hitting, you want it on a really light TENS, just enough to get cranial nerve 5. And you beat cranial nerve 5 for 30, 40 minutes, depending on the patient. A 15-year-old, maybe 20 minutes, 30 minutes, 20 minutes is enough. But on an adult, you do a little more. And what I do is with that alignment guide, I'm just holding that there. I'm not telling them to bite on it. I'm just telling them to rest there. But it's centered. It's their lower jaw. A lot of people, their lower jaw is going left or right. And so what this is doing is we're looking at like the frenums on the teeth and the upper frenums, and we're lining everything up with that alignment guide. So I've got, when the TENS is beating, I've got them centered, and I've eliminated any trajectory problems with my TENS machine. And I'm just trying to get what I say posterior decompression from these muscles on the bottom of the jaw, and I get it to relax. And all I do is I just pump the these are double TENS here, but I just pump the material in between the back teeth, and I'm done with my bite. And I'm checking the muscle data at the same time, and I'll show you how I do that. So this is a patient here, and each one of these sensors, I really only look at 4 sensors. I look at the anterior temporalis and the masseters. And when you look at this scan here, the red muscles are the temporalis anteriors. That's these muscles here that are coming across the temple. And they will pull the jaw back. And they're the ones that land on that coronoid process. That's right and left. Dark red, light red is right and left. The green muscle, the green lines are basically the masseters that are used for clenching. Christy was saying she's got a nice strong masseter from clenching. But when you're resting, we want to see these muscles really low, like you can here. You can see how low the data is when they're resting. What I'm having them do in the second part of the scan is just have them bite gently on their back molars. And then not hard, just enough for, like we say, 5 microvolts. When you're clenched, you could go 100 to 300 microvolts. We're just bringing them, we're going into MIP, like maximum interfluxation, just light CO, light centric occlusion. And just enough, 5 minutes. If you see the temporalis anterior firing like that, that's a pathologic bite. These are posturing muscles. They shouldn't be firing when you just bring your teeth gently together. And I have a little video I could show doing that on how I use the muscle data just to kind of diagnose whether a bite is good or bad. I'll play one of them.
1.0. When we ask the patient to go into what we call light CO, light centric occlusion, and you can see that the masseters are at 3 volts and on the right and 2.2 on the left. Now, when you see the TAs fire like this and go crazy, that's a bite that is not healthy, because these masseters are working hard to try and posture his head properly, and they're overworking.
I meant temporalis
anterior. Could be getting a lot of headaches and TMJ pain. Just when they bring their teeth gently together, all these muscles fire. They shouldn't fire, they should be more calm. If we go to another patient, and I'll show you the difference.
Hi.
Open up another one.
Come on in.
Thank you.
Yeah, there's pizza.
Let's see.
Yeah.
When you look here, let's see. You can see here that when she's resting, her TA left and right is about 2 microvolts, and her masseters are about 0.9 and 1.3. When we ask her to gently bite onto her teeth, she raised up from 1.3 to 2.5, so she's biting a little bit. She's just barely bringing her teeth together, and the TAs almost stay the same. This is a much healthier patient, and this is much more what we're trying to see when we're looking at rest versus a light centric occlusion rest. And that's that.
Let me see if I have another video like that. Do you guys like these? These showing the muscle data. There's one.
Where do you get your equipment? BioResearch?
Yeah, that's BioResearch. But there's 2 companies. There's Myotronics, and they're in Seattle, and then BioResearch. They work together, and then one guy split off and started a competing company. And
Third one now?
no, the second one.
Oh, that was BioResearch.
BioResearch,
Oh,
yeah. But they're both good. I just use the EMG data. I don't use the jaw tracking.
Yeah.
I eliminated the jaw tracking with the anterior alignment guide. I don't worry about the trajectory anymore. I just before when we didn't have an alignment guide, move your jaw to the right, move your jaw to the left. It was impossible. And so now I just make a little jig for the alignment guide, and I know I have the patient tensing completely centered the way we like it, with everything in the right place. Let's see what this one's all about. This is called a clench test, but
What we're looking at here is what we call clench and cut and roll clench. So we have sensors on the temporalis anterior and the masseters, left and right side. When the patient is resting, you can see the muscles are much more calm, and then she bites as hard as she can onto her teeth. If I right click here, you can get the microvolts, and the microvolts are the TA right is 66, the TA left is 89. The masseter right is 32, and the masseter left is 69. When she bites with cotton rolls, and I click here, you can see that all of a sudden the microvolts go up from 66 to 114, 89 to 185,
So
32 to 96 on the masseters, 69 to 168. And so the reason why this is so powerful is it's telling you that when she bites as hard as she can on her natural teeth, that there's a lot of interferences on her teeth, and her body's somewhat timid or scared to bite as hard as she can. So she resists a little bit because she doesn't want to feel pain. With the cotton rolls, it's soft. It's like jumping onto a mattress bed. You know you're not going to get hurt. And she can bite as hard as she wants without the feeling of there may be pain coming. So you can see that she probably has a lot of interferences and problems with her occlusion in her natural bite. And if we can get rid of that and get her a bite that feels comfortable, like she's jumping on a bunch of pillows and a mattress, she can increase her muscle strength and recruitment by a lot.
yeah, that's called a clamp. So I just do those two tests is all I usually take when I'm when I'm taking a bite. And here's a patient with sort of an alignment guide in the center, and all I'm doing after tensing is squirting the material in. But I'll squirt all the way across, all the way into the whole thing. And then to make the trial bite is I like to do it digitally. And so what I do is I actually scan the bite. After they take the bite, I scan it in that position with the iTero or the Trios. And you can see this is how the bite is at the end. See all this space in here? I want to fill that in with teeth. That's actually the bite that I'm looking to build. And I'm going to show you digitally how fast it is to make one of these. I make my own orthotics pretty much. But
move the bite into the proper position. Because of digital impressions, when we took the bite, it holds the bite in the physiologic correct position. So I want all these teeth to touch, and so I want to bring the teeth and eliminate this space. And just so you know, the whole thing will just go right up like this, and I can get it to touch. I can see if it's touching or not.
When I try to see the usually red lights up there, it will show me if I'm hitting or not, so I can reduce it. But I just do my own lab tech work, and I just I really love the digital stuff that's been going on with the labs.
Right up into the space, and that's all I have to do, and that's the end of it.
Yeah. So
Go over how you captured this bite.
okay. So
Tensed them.
I tens them with an alignment guide in the mouth during
That's
tensing.
the thing you
Yeah.
do.
And
You
then
don't position them.
what?
The alignment guide doesn't hold them in position.
It just lets them rest centered. It's just we don't want them to bite on the alignment guide. We want them to just relax on it and let go of it.
But
So-
it has the indentations of their teeth.
Yeah, yeah.
So it must position them somehow.
Yeah, positions them, just centers them. And then you're looking at the EMGs while I'm doing this. And the EMGs should be low when I'm squirting in that bite material. It should be nice and calm in there. So that's the idea of it. After 30, 40 minutes of tensing with the alignment guide, I'm just squirting it.
So nothing's really holding a position. They're kind of self-holding themselves in position.
They're just resting.
Yeah. It's kind
They're
of
just letting everything rest.
Okay.
So that's how you're determining vertical.
That's how I'm getting the vertical.
Just by the resting and the muscular.
Uh-huh. After tensing for 40 minutes. And then that's all that freeway space. I'm just going to fill it up with teeth that's there.
So after you take your bite registration,
Yeah,
now they're biting on a bite registration.
correct.
Do you test their EMG? Activity?
Yeah, exactly.
Okay.
And you have them,
Verifying it.
you saw them just bite a little bit, like 5 microvolts, and you see the TAs not even move. Okay, we got a bite here. You see what I'm saying? And then I bring it over digitally, and it holds it in that spot the way you digitized it. And so all I have to do is lift those teeth up on the thing, and it goes right up. And there's things you have to do to make it so that you can print it. And then I print it, and I put it in the mouth.
So you're
Just-
making like a PMMA?
Yeah, just like we're doing temporary veneers,
Okay,
we're going to make a temporary bite over the lower. I'm going to etch, a spot etch it, and I'm going to put it down over it. Let me see, let me get to the next slide here. Yeah, I'm showing you how to do it right here. So it's just like doing temporary veneers, but I'm doing a trial bite with it. I'm making the trial bite, and then once I put the bite in, and it's really close, that's when I like to use a T-scan. And so, let me see.
So you design it, print it, and then you make a Shojet mold.
Uh-huh.
Okay.
And I put it over the mouth, and then I make sure that I get all those teeth touching each tooth. I like to have the palatal cusp hit the central fossa. And I don't like really the buccal cusp hitting the lower buccal, hitting the central fossa on the upper, because I get a lot of interference on the inclines when they're chewing. And so it's easier for me to set the occlusion on the palatal cusp hitting the lower central fossa. I do really well, and I eliminate any weird inclines on the upper buccal cusp, so the lingual facing buccal cusp when they're chewing. So I'll put gum in their mouth and blue paper and have them chew 5 times, and I'll look in the mouth and I'll eliminate all those interferences. And it works really well. So when you look at all these blue spots, the question is, okay, which tooth hits first? Which tooth hits hardest? It's impossible to know. Blue paper, I like it because it shows me where they're contacting, but about that, I try to use a T-scan. And a T-scan, I don't like using a T-scan as someone in a habitual bite who has a pathologic bite. I don't want to adjust a bite in that position. I'm only going to make it worse, even with the T-scan. I like to move the bite to a physiologic correct bite, and then I want to adjust it in with the T-scan. I want to know which tooth is hitting first. So this spot here, this pink spot, it says that the bite is only 19% of the force. And so you adjust that, and then you have them bite again, and you keep going until you get a nice even bite. It does sync with the EMGs. I do use that sometimes. But
So this is after you cement it in your lower appliance.
and now I'm adjusting.
You're adjusting that.
Now I'm adjusting the bite. I don't like anything touching in the anterior. I want group function. I want them to hit at the same time. All 4 teeth on each side bang at the same time. I want to see 50-50 down the center. I want the forces to go straight up the head this way. And then when chewing, I don't want any interferences. I want it out of the way. Let's see. So that's pretty much what I'm going to leave that orthotic in. When I put one of those in, I always check them the next day, because you want them to eat on it now for at least 1 or 2 meals, because things happen. And it's amazing how great that second appointment is, because patients will come in and they'll say, it's sort of rubbing on my tongue, and it didn't create a lesion yet. So you can smooth it out, or this is bothering me, or this is weird, or I just notice I'm hitting this side first. And then so it gives me an extra opportunity to get it really, really comfortable. Then I'll see the patient 1 week later. And usually they're doing really well after a week. And so then after that, we see them, I don't know, 3 weeks later. But if they're not for TMJ and they're there to get all their teeth done, even after a week, you can maybe start to think about scheduling them if they've got 0 symptoms and no problems whatsoever.
So if you're not building an anterior guidance, you're building a posterior group function?
I'm good. Yeah, I'm
You're
not.
not building an anterior guidance?
No.
So group function in the back is what
Uh-huh.
you're building. Okay.
I'm building all group function. I've always done that. And I mean, I've been doing it because I've been a dentist for 35 years, and I've been doing hardcore full mouth rehab restorations my whole career. I've never really had a problem where, when you're a dentist, like, say you make a post and core, patient comes back 3 weeks later and they busted it off. And you go, wow, I can't do that anymore. I can't use this material. I can't use this. We're always making changes when we see problems. And so maybe I'll just extract, next patient I'll extract and offer them an implant or something, not try a post and core, or I'll get a different system. But it's the breaks, it's the people that come back, the people that have a problem that makes me say, I got to shift, I got to pivot here and change what I'm doing because this isn't working. But with group function, I've never had that feeling that nothing's happened. Whenever someone comes in with a broken veneer, I'll ask myself, habitual bite or physiologic bite? It's almost always the patients I'm struggling with are the people with the habitual bite who did 8 veneers in the front and 8 on the bottom. And, I'm all compressed from their bite and I don't open up, I don't have the room to keep these free and healthy in the front. So that's how I do it. So, so a lot of times I will make one of these. That was a lower wax up that you saw. If someone ground down all their teeth, upper and lower, I may make the orthotic top and bottom. I'll just make a perfect wax up with perfect teeth, and I'll put it on the top and I'll put it on the bottom, and I'll just glue it on top of their teeth and bond it on and adjust it that way. And it's a full mouth rehab, but I haven't prepped yet. I just threw it on top of their teeth and let's see how they do. I carve them up all different ways. I've had patients with really bad curvus Bs on the bottom, on the lower bottoms and the uppers. And so I'll just, cut a knife on the horizon. I'm just gonna do the posterior teeth on the upper and the posterior teeth on the lower. I'm gonna leave all the anterior teeth in place and that's how I make my orthotic. So I carve them up differently. Whatever the patient needs is how I fix it. And I'm always trying it out first with these trial things before I'm actually doing the work. So I put in this thing, they usually love it, and then for sure they're doing it. So it's a good way to know who you're getting in bed with your patient. Because if you're going to do a full mouth, it's a psychologically, it could be a difficult procedure. And patients aren't psychologically ready for it, you can't do it. And so it's a good way to back out if you feel like you went too far, even going to phase 1 and trying to get the green light for it. So I like to prep all my teeth in one visit. And I know that seems crazy, but I've trained myself to do it. I'm going to explain how I prep a full mouth in one visit. And I think it's a lot better to do it. You get everything over with in one visit. If you just do half a mouth and then you want to do the other half on another day, the patient could get gun shy. It's a tough procedure and it's a lot of teeth to do and it's a lot of hours and they may not come back and you lose the case. And so I just decided I'm going to prep just do it all. And I figured out how to do it. The lab appreciates it as long as you hold the bite properly and you maintain that bite that you found in phase 1. You want to make sure you keep that bite. And so I do it all in one major visit, prep, and I bond all the teeth in another major visit. So I call it 2 major visits. And the key of doing a full mouth in one setting is I use these 2 things. I use a clock and I use Alexa as a timer. And you have to watch the clock. It's a very intense procedure. And if you're not watching the clock, they can get away from you and you can be in there for hours. So I always start at around 7 a.m. You want to make sure the patient has all their forms filled out, consents, everything done prior to doing the visit. They are ready to go. And so at 7:05, I want to be injecting. I always start on the lower. And the reason why I start on the lower is I like to just give a couple blocks and not a lot of local, and then let the patient get really, really numb on the lower. It's a medical, when you're looking at doing a full mouth, you have to be very careful about how much local anesthetic you're giving over this time period, because you don't want to kill the patient. And you want to make sure the patient has, and there is a dentist that it happened to across the street, and he didn't even work on him. They just started, and I think it's like the first injections with the local, and the patient had a heart attack. And so that's why I like to, you don't want to numb the whole mouth and start. That's stupid. You just do the lower. I like the lower because it stays numb really long. So I start with just a couple carpules, let the patient get numb, and make sure, we always monitor blood pressure, and we usually give a pill, a little triazolam. I don't know if anyone's taken those sedation courses for oral sedation, but even one triazolam will make everything so much better. And if you don't have you don't want to do this procedure without some sort of sedative, because they remember everything. He snapped at the nurse, he dropped this. They'll recite the whole thing back to you. And if they're on a triazolam, they leave and they're the happiest people at the end, because time goes by fast and they're happy. So I do the lower, and I try to do about 7 to 8 minutes a tooth. And I'm going to try and go through how I kind of prep a teeth in 4 to 6 hours, start to finish. So meaning I like to be done before 12 o'clock. I start at 7. I like to be done before 12 because I want to have my lunch. And so I don't want to be working all day. And I like the morning because there's less interruptions. The phone's not ringing. People aren't bothering me. And I want to get this patient in and out efficiently. So what I do is you have to keep the bite. So if the patient's wearing one of my orthotics with the fake bite, the trial bite that we put in from phase 1, I leave it in there. And the patient's very comfortable in the bite. So what I do is I cut it on the first molar, or the 6s, and I prep from the 6 to the 1. The central incisor to the 6. I leave the 7 alone, the second molar. I prep those. What?
You're in London now.
I'm in London now, yeah. Does everyone know the 7s and the 6s? It's like yeah, so I leave the second molar, and I prep the first molar to the central, and then I take a bite. When you take a bite with that, you can't miss, because the 7 is still in there, and the bite hasn't changed at all. So the thing will go down. Then I go from the other side, the 1 to the other 6, and I take another bite. I leave the 7. So you can't miss. All you have to do is put the bite material in, push it down. They don't even have to close on it. But I always have them closed just to kind of see that, hey, I'm in and everything's good. But I know I'm in without them even biting, because the 7's holding it down properly. Then I'll do the 2 7s. And if I'm doing about, it's say 7 teeth times 7 is 50 minutes. So say an hour and 15 minutes. So now it's 8:15, and now it's 9:15. I'm kind of done. I prepped all of my lowers. And now I'm going to take impressions on the lower. And I'll take a digital, and I'll do because there's so many teeth, I always like to do a PVS. For the lab, I want to give the lab a couple things to look at, different. So I do a digital because I like storing my records digitally, and I want to give the lab both sets. So I give them digital, PVS, and I'm done with the lower. Say it's 9:30. I'm going to start numbing the top now, And I'm going to do the same thing on the top. As I say, it's 10. Now by 11:15, I'm kind of done prepping the uppers. And so 7 minutes a tooth. The anteriors seem to go a lot faster than the molars. If they have a lot of old restorations, it slows me down. I got to do build-ups and do all this stuff. It's crazy, you know, and you just keep going one tooth at a time. And, you know, once I'm done with that, take impressions, make temps, and I'm kind of finished at that point. And I'm trying to be done by around 12, but it's pretty good. When you're prepping the opposite arch at 10 in the morning, and you go, it's only 10 in the morning. You're already done with the lower, and you've already taken an impression, and you're going to finish this up. You know you're going to be done by 12. So that's how I kind of do it. When I insert the teeth, I do it the opposite way. I always start on the upper first, and I'll numb the upper, and I'll take all the teeth off, and I'll try all of them on. I usually have a lab tech on site, so I can do some color glazing if there's something's wrong, or if the margin's not 1,000% perfect. We want to have the lab tech fill it in. And so sometimes I'll try top and bottom on if the lab tech has to do some work on that after we tried them on. But if everything's good on the upper, I'll try the upper on. Then when you try the lower on, I want them to close in on the upper. I want to make sure all the teeth and I'm getting a really good intercuspation. They can have the bite off. If you look in the mouth and you see one side all touching and the other side's up, don't think to yourself that you're just going to lower this side. That's the wrong thing. You could put the one in that's touching and then leave those 4 teeth out on that side on the bottom. Just take a new bite over it and send it back to the lab and have them raise the occlusion up. It's never bring the occlusion down. It's always build the occlusion up. So if I'm not putting all the teeth in, if something's wrong, then you want to check the bite for sure. And usually we get the patient's approval, we try them on, they look at them. We always want to make sure the patient sees them. Then we give the sedative. We don't give a sedative until after they see him, because they'll say, hey, I was on drugs when I signed this. So we wait till they look at him, approve him. We just do the top for that. We use an Optigate. I used to use a rubber dam, but I use an Optigate now. And it seems to work really well. And that's that.